I'm Brenda Gamble. I'm a member of the Canadian Health Workforce Network, and I'm the theme lead for healthy work environments and retention. And I have a cold, so if you hear me gasping, that's what it is. Nothing to worry about, just the way it is. So the fifth session, the fourth panel we have is on integrated models of primary care. Primary care has been chosen to focus for this panel that brings together key national initiatives and research programs examining integrated models involving a broader range of health practitioners. So we have 4 panelists: Louise Nasmith, Professor Emeritus from UBC and co-chair of the Interprofessional Collaborative Table of Team Primary Care, Training for Transformation Initiative. Welcome, Louise. From the United Kingdom, we have Kath Checkland, Professor of Health Policy and Primary Care Health Organizations, University of Manchester. Welcome, Kath. No, I'm short, but anyway. From Australia, we have Susan Nancarrow, CEO, HealthWork International, Adjunct Professor at Southern Cross University. Welcome, Susan. And from the United States, we have Brianna Lombardi, Assistant Professor, Department of Family Medicine, University of North Carolina, Chapel Hill, and Director of UNC's Behavioral Health Workforce Research Center. So the format of this panel is the same as the previous one. Each presenter has 12 minutes. And so let's get started. Louise, I'll hand it over to you.
Thank you very much. I am presenting on behalf of a very large team, an initiative called Team Primary Care Training for Transformation. There are 2 co-leads, Ivy Bourgeot, whom you all know, and Ivy Anderson from the College of Family Physicians of Canada. The question, of course, is why team primary care? And as in many other jurisdictions across the world, there has an acknowledgement that in Canada we have a crisis in access to primary care. This was accentuated during the pandemic, and certainly we've seen it post-pandemic, in part due to a number of family physicians who are the main entry into the healthcare system in Canada. Some of them deciding to retire early, even young people deciding to stop practicing, and a number just deciding that they would focus their practice, that providing comprehensive care was just too hard in a system that wasn't supporting them. This has resulted in at least 6 million Canadians out of 42, roughly million in the country not having access to a regular primary care provider. And we anticipate that 1 in 6 family physicians are nearing retirement. So of course, our enlightened governments sometimes think, well, let's just produce more. But the reality is that isn't going to solve the problem. We have recognized, and you're going to hear this, I think, in Kath's presentation, that providing primary care in teams is one of the solutions to help stabilize and, importantly, to sustain our healthcare system. And we've certainly heard this from our graduates saying, give us these kinds of models to work in, and yes, we will be happy to provide comprehensive care. However, that just putting people together in practice does not necessarily mean that they are going to know how to work together. And over 20 years ago, a review of our healthcare system by Roy Romano, one of his statements, which we continue to quote, and I do today, is if you're expecting people to work together, you'd better educate them so that they know how to do this. Hence, team primary care. The focus is on education, not so much on the practice. And I think Kath will be talking about that in the next presentation. I mentioned this is a large project. We have over 100 partners, and there are more than 20 primary care disciplines who stepped up to the plate. This is a project funded by the Government of Canada. There was a call that went out saying, are you interested? And surprisingly, and you will see in the next slide, we had over 20 different disciplines saying, we want to be part of this. It has resulted in 14 team training projects and a number of other groups that, who didn't get funded, but who are working with a little bit of seed funding to try and do the same thing. Ultimately, we are asking them to prepare or to alter their curriculum in order to enhance, to increase, to align preparedness for team-based practice in primary care, and ultimately to improve access. What's our vision? It is about integrated health. It's allowing each individual in Canada to receive equitable, high quality, comprehensive care from a well-trained, well-supported, and optimally utilized primary healthcare system. A lofty goal, but one that's critical to really allowing our healthcare system to function. And our mission is about training, educating, equipping the workforce to be able to do this. We've gone back to the 4 primary care core functions, work that you saw in some of Starfield's initial work, about first contact, about comprehensiveness, which is critical, coordination, and continuity across services. But we've added 5 principles in which we've been asking the projects to embed their curricula. And those are obviously interprofessionalism, but also equity, diversity, inclusion, and accessibility, truth and reconciliation that Canada is committed to our Indigenous people, psychological health and safety that became all that more important as we saw during the pandemic, and social accountability. This all has to meet community and patient need. So how are we doing this? Well, we've talked about our mission, or I've talked about our mission. And what has happened is that we have 3 types of projects. One, and probably the largest cluster, look at practitioner-focused pre-licensure training, curriculum for our undergrad students, if you will. Some are looking at practitioner-focused in the professional development realm. And then there are a few focusing on teams already in practice. The Interprofessional Collaborative Table that I have the pleasure of co-chairing with 2 colleagues has brought together the projects involved in those first 2. There is a team optimization table looking at those in practice, and providing resources are cross-cutting supports focusing on the principles that I spoke about earlier. There has been a very comprehensive and embedded developmental evaluation, not only looking at outcomes, but looking at many of the process issues all along the way. I'm going to be talking specifically about that interprofessional collaborative table. So if you look at these are the individual professions or providers groups who stepped up to the plate. And some are no surprise, family physicians, nurses, pharmacists. But surprisingly, if you look, you see also medical laboratory technologists, medical radiation technologists, Indigenous healers. And all of these individuals are working on projects that ultimately will allow them to move their graduates into a different realm so that they learn about, they learn with, and they learn from each other. So how have we done this? I will admit that it has been a sort of emergent and sometimes a little messy and definitely iterative process to try and decide how in the world would we work with all of these groups to get ultimately to the aligned and scalable training and coordinated resources and to allow their curricula to move in this direction. And we have sort of 3 steps that have come into play. The first, looking at, can we agree on the primary care services, the primary care domains that we actually are talking about? Once we agree on those, are you able to map your scope of practices, your core competencies to these domains? And then we move into the alignment of learning objectives, competencies, and accreditation standards. And I will talk about each one of these steps. So the first one, around agreement on primary care domains, ultimately ended up with a type of matrix. The first dimension has to do with community patient focused, population health, case management, social care. The second is about the services, everything from prevention to mental health to chronic care to substance use, et cetera. And here's the list. And then you provide all of these across the life cycle, from preconception all the way to the end of life care. Step 2 was mapping the domains to their practitioner roles, to what they could do. And so this is one example only. We said, if we agree on these domains, so tell us how you would contribute. How would your profession contribute in these areas? So looking at chronic care and the personalized approaches to multimorbidity, I will not expect you to read all of these, but what was the most interesting, you might think it's the identification of each group as to what they could contribute, but equally important was realizing what others could contribute. Some people said, I had no idea that the lab technicians could do this, or that the audiologists could do this. And so it started opening up a broader view of what primary care could be, and ultimately how they as individuals, as uni professionals, could start collaborating across the system. The third step was the alignment piece, and we still are working on that, but we are getting there. And in some ways, the first bucket is the first step in terms of, if these are the domains, if this is what you think you can do, how do your core competencies align? And for the most part, we weren't asking individual groups to redo their core competencies. We were just saying, how do your core competencies fit and what's missing? And for the most part, as we have started to hear back, what's really missing is that collaborative practice piece. Despite the fact Canada has invested in interprofessional education over the last 15 years, many would say we don't really provide them with the opportunity to learn primarily with other health professional groups. How do your learning objectives? So let's move back and go to learning objectives. How do they align? What's missing? And the last column is about accreditation standards. And so we recognize that certainly in Canada, as I'm sure in many other jurisdictions, accreditation can really be a significant driver for curriculum change. So recently we've engaged the accrediting organizations. Every health professional program has to be accredited by national bodies in Canada. We brought them together. We said, this is what we're doing. Do your standards actually at all help with this? If not, how can you potentially enhance them? And what could we do to help you? And we're hoping this will be the beginning of a conversation among the health accrediting organizations, because they don't all have to recreate the wheel, and we all have to be aligned. So that will be probably work that will continue on after this project is finished. So putting it all together, what are the care domains? How do your core competencies fit? Can you tell us what you do? Can you start seeing what others do? How do your learning objectives fit? How can you start thinking of learning activities that would allow you to move? And how are the accreditation standards going to actually assist you in being able to make these changes? I take a big breath because this has been a significant amount of work over a very few months. The showcase of all of this will be at a summit in February in Ottawa, a very cold month in our capital, where we will ask each one of the projects to showcase what they've done. We will have others there, others who are important in making system change, because although I said this is about education, the practice has to also reflect it. And in Canada, healthcare is the jurisdiction of our provinces. The federal government sets direction, but the provinces enact all of the changes that have to occur. And we need to really engage them into supporting the new models of care. So I will ask you, if you want, you can get way more information. There are videos, et cetera, that will give you more information at this particular website. And I thank you. And I think I'll pass this back to Brenda.
Thank you, Louise. Being a part of this team is very fast-paced, and Louise has given an excellent overview of the whole process. Thank you. So I invite Kath Checkland to now present for her presentation.
Thank you very much for giving me the opportunity to present today. I'm sorry for my rather peculiar lighting. It's 7 o'clock at night here in the UK, so I look like I'm in some sort of dark cave, but it's just the lighting in my room, so I'm sorry about that. So I'm going to talk to you today about what happens if you don't do what Louise has just so nicely demonstrated about interprofessional education. So I'm presenting on behalf of a large team who undertook a study in the UK looking at what we call skill mix change, which I think is the same thing really as team primary care. We're introducing professionals with additional skills and different roles into primary care practice. So these are just the acknowledgements. So we're funded by our NIHR, with the National Institute for Health Research. They require us to tell you that these are my views and not those of the research funders. And most importantly, that the research was led by my colleague, Dr. Sharon Spooner, who's another GP, as I am. And she led the research with a large team of colleagues, and it was a really excellent piece of research. So just like you in Canada, we have a workforce crisis in primary care. All the same reasons. We have rising demand, we've got too few qualified GPs, we've got poor job satisfaction, newly qualified GPs are not working full time, and we have a consequent retention crisis. In fact, all of our newly qualified GPs are going off to New Zealand and Australia because they're nicer to GPs down there, we're told. So that's one of our big problems. We're training them, and then they're emigrating. And like everybody else, we're struggling with what to do. And obviously, there are a number of solutions, some of them more long-term, some of them more short-term, recruiting more GPs. And we are making some progress on that. We've got entries into training have gone up. But of course, if they all go off to Australia and New Zealand, we have a problem. How do we prevent people from leaving? We're not making much progress here. I think we have a vicious cycle, which I think is probably true in other systems as well, whereby the harder the work gets, the more pressured people feel, the more they're likely to leave, and then it gets worse for the people who are left behind. So we have a kind of spiral going on, which is a real problem. And so obviously, one of the other solutions is to employ other clinicians to do some of the work, which in the UK we tend to call skill mix change. And that's the thing that our study looked at, and I'm going to focus on here. I think it's important to say that the skill mix change we're looking at, this is the field work on the study was done a few years ago now. And certainly what was happening, unlike what Louise was talking about, where they're very careful interprofessional education, really everything was done piecemeal. We had a lot of people were panicking. They had no staff, and so they were employing whatever types of staff they could get. So it wasn't a particularly planned change. It was something that happened over time because people couldn't get GPs, because the GPs weren't there to employ. And so what we did in our study, and what I'm going to present here, is we said, okay, if we're going to evaluate this, there are many, many ways in which you can evaluate such a change. What we decided to do was just to look, and the bit I'm going to present here, but it's a very large project. There's a very long report, which I'll put onto the slides, which can be shared later, so where you can look at the kind of the detail of what we did. But for this particular presentation and for this bit of the work, what we did was we looked at what we call the program theories, and what we mean by that are the kind of underlying theories of change, which the policymakers who were driving the changes that were happening, what they thought would happen and what the benefits would be of broadening the skill mix in primary care. And so these things that I've put on this slide are derived from the official documents, the policy documents, the guidance that was going out to GPs to say, if you can't get GPs, you can employ other people. And there were various funding streams which supported this. And so we distilled out of these three main kind of, if you like, justifications for why this was a good idea. Firstly was the kind of, in some ways, unobjectionable comment, which is that some routine primary care doesn't require the specialist generalist skills of GPs and can safely be distributed to other staff. It was then highlighted, it said, oh, this is good, because this will free up GPs to work at what was called the top of their license, which will improve their ability. They'll have more time, they won't be seeing the routine stuff, they'll have more time to provide complex care for patients, and that will increase their job satisfaction, they'll enjoy themselves more. And then obviously there's the final point, which is the fact that increasing the diversity of clinical skills is a good thing in its own right. It'll broaden the care available, it will improve population health, and it'll support more integrated care. So what happened in practice in each of these what did we find when we looked at this in practice? So the work distribution, clearly other types of clinicians can provide safe and effective care for some conditions and for some elements of care that's provided in primary care. But what we found was, because the patients in UK primary care, the patients who present are undifferentiated. So they turn up at the front door and they can have anything from an incredibly complex problem to something really routine. And so getting them to the right person who can deal with their problem requires really complex practice routines and processes. And those have to be worked out very often on the fly, because different people that you employ in the same role may have slightly different skills. So, for example, one of the things we found in our study was that advanced nurse practitioners came with very different backgrounds, and some of them had mental health experience, some of them had, and so the practice staff were having to quickly work out what different people could do, make sure people went to the right person. It increases the patient work because they have to engage with this process of who are they going to see, and it can be confusing. You obviously can get some duplication, because if the initial clinician can't deal with the problem, they have to go somewhere else, and the staff requires supervision and training. And so from that, we found that obviously the time saving for GPs may be more limited than you would think, because they're doing the supervision, the training, and they're picking up work that other people have found needs to be transferred. From the patient perspective, these are just some quotes from some of the people that we spoke to in some focus groups. And the first quote, they have an online triage. Patients found it difficult to negotiate. There was a website, but it wasn't obvious. And obviously, the potential there is to increase inequalities, because people with good IT skills will find it easier than people without. And obviously, people who can't go online at all will struggle. Another person said, that my husband's got multiple problems, and every time he seems to see a nurse, they say, oh, I think you need to see a doctor. So this sort of duplication thing. And sometimes people told us, well, they didn't like the fact that they couldn't necessarily choose, that they were told which type of practitioner they were going to see. So the idea of, well, will it free up GPs and improve their job satisfaction? We found that really it wasn't really clear that GP's time will be freed up because of the need for supervision. And we also found that people found that actually constantly working at the top of your license can be quite hard to sustain. I've been a GP for more than 20 years. And actually a sore throat or a urine infection, halfway through a busy afternoon is a really good thing for me, because it lets me get my breath, it lets me catch up, it lets me get so something that's easy to deal with in the middle of a hard working day. Constantly dealing with the most complex patients is not necessarily going to increase job satisfaction. And we also found that these are some quotes from the GPs we were talking to, and they were saying that actually it's really complicated. So even newly qualified GPs can't necessarily jump straight into a complex multimorbidity role. And so that they were actually having to create tiers of GPs within the practice. And that's fine, the more senior GPs and more experienced GPs can support their colleagues, but actually that takes time. And so then it doesn't actually free up anybody's time, because they're doing this supervisory role. Similarly, one of the other GPs told us, well, actually, I'm supervising the other practitioners even through the lunch break. So I don't even get to look at my own clinical workload until the end of the day. And you're trying to support them, and obviously they'll gain new skills over time, but it's taking a lot of time and effort for the GPs involved. And they told us that losing the simple stuff was definitely a mixed blessing. Definitely, there's a broader range of care available, and this works very well for some things, such as physio, musculoskeletal problems, clinical pharmacy for complex people with complex medication. But it does require these really excellent coordination mechanisms. And you can find that the definitive diagnosis might be delayed, as patients initially consult with an apparent problem, consult one practitioner who says, I'm not sure that's quite what I can deal with, we'll have to move you on to somebody else. And people told us about duplication. They said, you know, that there's pharmacists and nurses, and sometimes people, you think somebody needs to see a certain person, but actually they need to see somebody else. And the quote at the bottom, there's somebody telling us that, well, this was a clinical pharmacist saying, well, I'm doing the complex medication review for a diabetic, but of course they still need to see the nurse to have their feet checked. They still need to have the sort of physical element, and the pharmacist can do a wonderful job with the medication, but they can't look at the feet. And so the patient's making more trips to the practice. So in summary, our study found that skill mix change is obviously a solution to the current crisis that we have, but it brings with it really significant complexities, and it requires careful thought and careful design of internal processes. And as Louise has clearly pointed out to us, it needs careful training too. You can't assume that GP time will be freed up, and we really aren't seeing yet whether or not this is going to halt the slide in GP job satisfaction. And we found patients who had both negative and positive impacts. I've highlighted today some of the more negative ones. Obviously, people had positive experiences too. But I think the thing I wanted to highlight was that a lot of the simplistic assumptions that underlie policy changes are not borne out in practice, and that you're making complex changes in complex systems, and that actually requires an awful lot of adaptation, which isn't necessarily straightforward. And just finish with a sort of personal reflection, really. I'm an old-fashioned GP. I trained many years ago. I like holistic care. I don't think general practice primary care can really be broken down into tasks of different complexity, because every patient with a simple problem probably also has in the background more complex problems going on, and vice versa. I think even when you can break things down into into tasks, you have to then fit those tasks back together into a whole, which is a complex jigsaw. And I'm at the end of my career now as a GP, but certainly my satisfaction was driven by the extent to which I could offer whole person care. And I am sad that that's one of the things that we seem to be losing. Thanks.
Thank you, Kath, and thank you for sharing your experiences and sharing with us the complexity of the skill mix change. Very important message. Thank you. Next, I'd ask the CEO of HealthWork International, Susan.
Good morning, everyone. I'm actually in Australia, and it's 6 a.m. on Saturday morning, and some of you may be envious to know that we're going to have a heat wave here today. It's 30 degrees. In actual fact, we'd be very grateful for a little bit of snow right now. I'm a health services researcher and have attempted to make a career over the last 25 years looking at the allied health workforce. And I've been lucky enough to work across numerous jurisdictions, mostly the UK and Australia. And Australia has 8 different health systems, slightly different health systems, and we're also doing some work in Malaysia at the moment. So what I wanted to do, and I've really enjoyed the presentations by Louise and Kath. I want to zoom out to the macro perspective of allied health and the opportunities that we can use to make a difference, but also the challenges. And I think Kath alluded to several of these, and as did Louise. So the allied health professions in most jurisdictions make up around 30% of the overall workforce, but I say that we're siloed by profession, often by jurisdiction, often by teams and organisational ways of working. And so we end up working in micro silos. So it's actually very hard to mobilise and engage the allied health workforce. So what I really want to touch on are some common problems, and Kath really set this up quite nicely, as did Louise, around the opportunities, particularly in primary care, when we're seeing huge workforce shortages, for allied health to step in and do the things that they do if they were to work to their full scope of practice, but also look at some of the barriers to us mobilising allied health. I thought I'd first touch on the contribution of allied health to high value care. I suspect I don't need to talk about that really to this audience, but then talk about the global challenges of mobilising allied health. And it largely comes down to some system problems, but again, Kath highlighted those quite succinctly from a single general practice perspective. How do you actually integrate multiple professions in a primary care setting, particularly if we've got different funding and organisational models. And then at the end, I've got 2 examples of projects that I was involved in nearly 10 years ago, where we really tried to engineer that in the Australian healthcare system. I won't have time to go into them, and I've got links to the reports, but it might be a useful context for discussion. Before I go into what is high value care, I know that we all think differently about what is allied health. As I said, I've been studying this for 25 years, and look, I'm down to a very pragmatic definition. I include anything in allied health that is not a doctor, a nurse, or a dentist. And the inclusion and exclusion criteria in every jurisdiction have more to do with historic funding and regulatory models, and generally accidents of policy. And I'll also say that I include psychology, pharmacy, and midwives, if that's what's included in the jurisdiction. And I know that they variously have very strong opinions about whether or not they're in or out. I want to focus on high value care because not only are allied health professions often forgotten, this is actually where we can really make the difference. So we tend to see high value care as, from a hospital perspective, often not doing procedures that we know don't make a difference. I think knee arthroscopies have been in and out of fashion a few times, but I'd like to go to the New South Wales health definition. That's health outcomes that matter to patients, their experiences of receiving care, experiences of providing care, and really the effectiveness and efficiency of care. And I think we have some real opportunities with allied health, and both Louise and Kath have talked about this, to shift the curve towards prevention rather than curative health. And Deloitte looked at the challenges to high value care. We don't tend to focus very much on the social determinants of health in our health systems. We're still funneling most of our resources into really things that should be prevented, but we don't get to them until they turn up in hospitals. So allied health are particularly good at helping people with social determinants of health. And I think both Louise and Kath have also talked about the need for interdisciplinary teams to deal with those complex social issues like mental health, substance addiction, and behavioural health, which are areas where allied health can make a difference. Again, I think Louise gave a lovely example of different types of interventions, and that I loved your interventions across the continuity of care and where allied health can make a difference. We did a research blog on 10 ways that allied health can keep people out of hospital, and this was 10 issues. They're all multidisciplinary, but I'd particularly like to point out 2. So emergency department triage, assessment and treatment. There's really good evidence now that putting allied health as first point practitioners in the emergency department, particularly around things like musculoskeletal disease and mental health, can avoid a hospital admission in the first place. And we also know that if we have allied health practitioners, again, for instance, physiotherapists and podiatrists, triaging surgical waiting lists, we can both improve the surgical outcomes or get people off those surgical waiting lists altogether. And that's just a small number of examples. I've actually pinched this from an early intervention model around education, but where allied health really fits is on the left-hand side, early intervention, prevention, early detection and screening, and that's where we can make the greatest difference. Unfortunately, the way healthcare evidence works, and I know that every academic in this room will appreciate this, it's much easier to prove the outcomes on the right-hand side of the diagram because the interventions tend to be tighter, and we tend to be looking at positive outcomes. Whereas the areas where we can really make a difference are those aspects on the left-hand side, but they take a long time to demonstrate outcomes, or the outcomes are much, much harder to illustrate with traditional epidemiological techniques. So I want to talk about sort of the macro issues that impact on health accessibility. And I think, again, Kath, you've talked about this to a certain extent. The first one is funding models. A beauty of the NHS, and Kath talked about the ability to substitute allied health professionals and other workers in primary care when we have a shortage of doctors. That works really well when everyone is funded under a national health system. So on the left-hand side, we've got centralised models of healthcare. And the opportunities you've got there is that you have policy drivers for what services are delivered and where they go. But really importantly, it tends to break down those competition barriers between providers. And just this week on the right-hand side, we've got devolved models or fee-for-service. In Australia, we have a mixed model. I understand in Canada, you have mixed models of fee-for-service and some centralised funding, which sort of fits in the middle. But it's really difficult to introduce true interdisciplinary working in primary care if people are working on a fee-for-service model, because everyone has an interest in maintaining their patients. And just this week and this year, we've got a very active pharmacy guild in Australia. They're trying to get some of the primary care interventions that have been mainstream in at least the NHS England for at least 20 years. And every time they try that, the Australian Medical Association rears their ugly head and tries to stop it, when we know that it would stop people going into general practice. There's actually good evidence around the benefits of pharmaceutical intervention. In the UK, they also have podiatric surgeons, and that's been another point of debate this year. We also have podiatric surgeons in Australia who can do day surgery on foot complications, but the orthopaedic surgeons are challenging that. And again, we've got this, as a sociologist, we look at who owns the capital, and I think those funding models are really important for driving opportunities for interdisciplinary collaboration. And one of the examples I talk about at the end is how we tried to engineer that. The other problem that funding models create is market drivers. If you've got a fee-for-service model, you end up with market drivers for health service delivery. And in Australia, this leads to market failure, because the service providers can only go where there's a market. We're doing some work at the moment around what we're calling allied health indicators of need. So we've looked at population drivers of allied health need, and this is an example of podiatry, and then map that with supply. So in this case, we've looked at the population indicators of need for podiatry, prevalence of diabetes, indigeneity, lower socioeconomic status, and musculoskeletal diseases. And we've pulled that into a single algorithm. It's fairly crude, and we've mapped it at a geographic level. And then we've overlaid that with the supply of podiatrists. So where you've got areas of high need and low supply of podiatrists, they're more green. And where you've got high need, more orange, I apologise. And where you've got greater supply with less need, it's more green. So what I've taken here, this is the whole of Australia, and you'll see our rural and remote areas are much higher need and less supply. The area where I've got my cursor at the moment is rural Western New South Wales, very high Aboriginal population, very high prevalence of diabetes, and we know that Aboriginal people are 30% more likely to have an amputation than non-Aboriginal people. And yet this is the Sydney metropolitan area where we can see that there is much greater supply and much less demand. And if you're working on a fee-for-service basis, you go where the patients are and you go where the money is. So this is one of the big challenges of fee-for-service funding models. Closely correlated with funding models is centralised and devolved systems of health organisation. So again, on the left-hand side, we've got more centralised models, and on the right-hand side, we've got more free market, locally driven models. And again, we've got the policy drivers determining where the services go. Centralised workforce planning. When I first moved to the UK 20 years ago, we had a primary health trust-driven group called a Health Workforce Confederation, which looked at predicting regional needs and commissioning those needs within a regional area. On the right-hand side, in Australia, our higher education providers don't even talk to the health system. And so we've had a proliferation of physiotherapy courses. We can use a few physiotherapists, but I think we've got 56 courses in Australia for a population of just under 30 million people. And so the university market drivers are the things that dictate whether or not we have supply of workers, with the exception of the medical workforce and to a certain extent the nursing workforce. They tend to be centrally coordinated, but it means that we don't have centralised workforce planning. Market tends to dictate who is trained. And that ultimately leads to less workforce flexibility. And again, 20 years ago, the UK introduced the European Working Time Directive, and we saw centralised coordination of re-engineering of roles. So allied health were doing doctors' work, GPs were doing consultant work. There was an entire cascade of the workforce, and at the bottom end where we needed assistant workers, people were being trained from manufacturing industry like potteries to come into support worker and assistant roles. And the last point I want to make is around health regulation. And again, at the one end of the scale, we've got state regulation. At the other end, we've got self-regulation. And I know there are people in this audience who are much better versed around regulation than me. But the point I want to make here is a highly coordinated, legislated workforce is also less flexible, and creates more rigid enforcement of role boundaries. Whereas a self-regulation model or a mixed regulation, say co-regulation, can allow new roles to emerge. And I'll give you some examples of those. In Australia, we have, again, a hybrid model, some state regulation and some self-regulation. The self-regulation model has allowed the proliferation of several new professions. Some of these are things you've probably never heard of. Developmental educators are a workforce that have developed in Australia over the last 10 years in response to the increasing move of people with disabilities out of institutions and into the community, and the social management of people with disabilities. So these are people that work with people with learning difficulties in the community to help their social outcomes and engagement. They've adopted a self-regulation model, call themselves an allied health profession, and they get state funding under private health insurance and public health insurance models to cover their roles. All of these roles have evolved in similar ways. Podorthists, you may have heard of, depending on your jurisdiction. They are orthopaedic footwear manufacturers, and again, they've used a self-regulation model and can access funding. I won't go into the others in the interest of time, but I'm happy to talk about those. But just to compare this, the allied health professions in England, they were established under national regulation in the 1960s under the Professions Supplementary to Medicine Act, and there are 14 professions that are recognised now by the Health and Care Professions Council, and this has stayed relatively stable over the last 60 years. There are a couple of new additions, but it hasn't changed very much, and that's partly because all of the professions regulated with the Health and Care Professions Council are also the ones that are employed by the NHS, so there's that sort of almost monopoly employer system. In contrast, these are the allied health professions that are recognised by the peak body for allied health professions in Australia. It's important to note we don't have a national body, government body for allied health professions. The professions in black are self-regulating. The professions in red are regulated by our national regulator. Several of these are a new and or emerging professions that have responded to society's needs. I just want to finish on two examples of projects that I've been involved in to try to get allied health into primary care. The first one, we looked at mapping service integration. So we looked at a regional general practice super clinic where the federal government put joint funding models together for collaborative care rather than a individual fee-for-service. What we found that the drivers of shared care were better integrated care, having shared medical records, having co-location of practitioners. We needed regional infrastructure, in this case, what is now called primary health networks, to drive those collaborations. But the real driver of those integrations and referrals was informal networks and relationships between the general practitioners and the people they knew. And this is a problem when we've got a high turnover in a regional workforce, those relationships get lost. And secondly, very quickly, this was a highly engineered project where the local primary care network literally paid to put allied health practitioners into general practice to see whether or not they could improve integration. The allied health practitioners literally had to go through the general practitioners' records, because we don't have shared records, to find examples of where they could improve the care of the patient through their integration. What we found is that it did improve care plan management, and it improved the knowledge and information sharing between practitioners, but it was a highly organised system and model. I'm going to leave that there and hope that creates some opportunities for discussion later. Thank you.
Susan, thank you very much. It's refreshing to see one talking about allied health and the factors that influence their accessibility. Brianna will do her presentation next, and she is from the University of North Carolina, Chapel Hill. So, Brianna.
Thank you so much. I want to say good morning to Susan, and good afternoon and good evening to the rest of my colleagues here. I'm so excited to share with you a little bit of the work that we've been thinking about when we're thinking about what we call integrated primary care or integrated behavioral health and primary care. I'm Brianna Lombardi. I'm a social worker by training, but now I'm an assistant professor, a faculty member in the Department of Family Medicine here at UNC Chapel Hill. I'm also the director of the Behavioral Health Workforce Research Center, which is one of the 9 federally funded workforce centers we have here in the States. Behavioral health here in the US is now our consolidated term for mental health and substance use conditions. And I'm also the deputy director of the Carolina Health Workforce Research Center. And the Carolina Health Workforce Research Center, which is directed by Aaron Freyer, is an emerging topics. And certainly I got into this work really thinking about integrated primary care as an emerging workforce issue. I want to thank our team members and our colleagues, as well as our funders. Although my work is funded by SAMHSA and HRSA, they do not condone or endorse any of the work I'm sharing with you today. Also just want to highlight the other centers that are funded by HRSA to do health workforce research in the US, along with the Health Workforce Technical Assistance Center at SUNY Albany that consolidates our work and disseminates it. And I'm really excited to kind of be the director of the Behavioral Health Workforce Research Center. We've been newly funded in the last 18 months and excited to share some work with you. So, integrated primary care in the US is really centered on kind of this growing understanding that primary care is inclusive of an interprofessional team that addresses all types of health, including behavioral health. The National Academy of Science, Engineering, and Medicine here in the US defined high quality primary care in a consensus report in 2021, where they updated a previous definition of primary care to include specifically the words of integration and interprofessional teams. And this report really tried to highlight or synthesize the different types of health occupations that might be working in an integrated primary care team. And certainly we could think about the primary care clinician, the patient, and the immediate kind of core team, but then included some of the allied health professions that Susan just was describing, but also includes behavioral health. So again, behavioral health is the inclusion of mental health and substance use. In the US, we have many different types of behavioral health clinician types, from clinical psychologists and clinical social workers to licensed marriage and family therapists, licensed counselors, peer counselors, and more. And I'll really focus today really thinking about the integration of behavioral health and primary care. And, the priority of the integration of behavioral health into primary care is just this high level of need of behavioral health need that we have in the US. Probably similar to the other countries that are here. The pandemic, brought a tsunami of behavioral health need. We have the highest rates of suicide in the last 20 years. We have an increasing opioid overdose pandemic or endemic. And at the same time as this kind of increase in behavioral health need, we've had stagnant behavioral health care access. And this is an image from the National Survey of Drug Use and Health in the US that has showed that mental health care has kind of stuck around 50% over the last 20 years. And we know much of behavioral health care that is in the US is delivered in primary care. So this is looking at data of office-based visits, who delivered mental health related visits. You can see on the left, in large urban areas, psychiatrists are delivering mental health care, but in small and medium metropolitan areas, and certainly in rural areas, it's primary care physicians who are delivering behavioral health care. Now, who is working alongside primary care clinicians to deliver integrated behavioral health? We're not quite clear. And part of this might be due to how we bill and how we see things within claims data within the US, as well as how we kind of document behavioral health workforce in the US. But we did an attempt here to look at the co-location of behavioral health clinicians with primary care clinicians in the US. And we geocoded behavioral health clinicians with primary care practice sites. And we looked at the proportion that were physically co-located. And as you can see, there was significant variation across the US, with the purple being high proportion of co-location of behavioral health and primary care, and yellow having low. But even when I talk about co-location, this is just one piece of many different types of models of integrated behavioral health models that are out there. On the top left corner, you'll see the collaborative care management or psychiatric collaborative care management, which is one of the models of integrated behavioral health commonly described in the US. And this one is has a lot of evidence behind it, but it also is one of the few models that has a payment code that aligns with it. So it's one that is being supported. But you can see that there are core features of integrated behavioral health that range from having an interprofessional team to having universal screening for mental health and substance use using standardized tools, having shared information systems that the interprofessional team can access. That creates those open lines of communication for sharing information and collaboration between the team, as well as a connection to community-based services. But what integrated behavioral health might look like in a primary care may be very different based on one of the models that was selected, based on the patient population, if it was an older adult or a younger pediatric population, or if they were in communities where you're serving folks with serious mental illness or substance use. But the care might also look different based on team configuration. And that is kind of speaking to what Kath was describing, that the different clinicians who are working on the team will adapt how integrated behavioral health will look like in primary care. And certainly this is based on payment. So the US is moving towards alternative payment mechanisms, but certainly is still firmly in a fee-for-service model. So understanding how to pay for these services. So we've had about 35 years of moving towards this behavioral health integration in primary care, where everyone seemed to be kind of moving in this direction. And then the pandemic happened. And then all of a sudden, one of the core features of integrated behavioral health, or this physical co-location or bringing together an interprofessional team, changed overnight. And so luckily or unluckily for me, I was actually looking at community health centers' integration of behavioral health and how they were paying for it. Community health centers, or federally qualified health centers in the US, are federally funded to provide care to communities regardless of their ability to pay. And I was really interested to see how they were using that psychiatric collaborative care management payment mechanism to increase access to care. But I was surveying community health centers in fall of 2020. So I couldn't ask them about integrated behavioral health without asking them how COVID-19 was also impacting their care. So this paper was recently published on the right. And, care was changing in part because of the ability for folks to use telehealth or telecommunication to deliver care. Prior to the pandemic, there was a lot of regulation on who was allowed to use telecommunication to deliver care, and had weird mechanisms in which that folks had to drive to a setting to get videoed into a person who's sitting at another setting. You couldn't receive care in your home, and the clinician couldn't deliver care from their home. And certainly we weren't paying it at parity to an in-person visit. But one of the major changes during the COVID-19 pandemic was the relaxing of regulations and the increase in payment for telehealth. And certainly this changed practice overnight. For the community health centers that I surveyed, about 30% were using telehealth prior to the pandemic, and more than 95% were using them after. And I also asked them how using telehealth kind of impacted the delivery of integrated behavioral health in their clinics. And they described to me different factors of how telebehavioral health impacted their setting. And the administrators that I spoke with really zeroed in on this change to the core components of integrated behavioral health. And I'll give you a few examples. So some really discussed that the team was no longer being seen by each other. This was a behavioral health administrator really talking about, because they weren't being seen by the doctors, they felt like that they were at a distance, and they felt like they weren't increasing the opportunities for trust or collaboration that's needed for this level of care. One of the core features of behavioral health integration can be what they call warm handoffs. And this is when the primary care clinician really introduces the patient to the behavioral health clinician and kind of makes that warm handoff and connection. And because of kind of de-densification of clinics and of kind of rules of how many people can be in those small kind of patient rooms, they were no longer able to do those warm handoffs. And so that those kind of connections and opportunities for collaboration really dropped. And they tried to do different things to actually increase the likelihood that they could do warm handoffs, like bringing iPads in or virtually zooming in the behavioral health clinician. But this kind of, the individual on the right-hand box really described it as clunky and inefficient, and it really didn't actually happen as they interpreted it to be. So kind of after this study, I was really kind of left or struck by this thought of, is integrated care being interrupted? Is this change that's happening based on the COVID-19 pandemic changing how we deliver integrated behavioral health care in the US? And so I was really interested to study about how the trends we saw in fall of 2020 was holding in spring of 2022, so 2 years into the pandemic. And I was also really interested in digging more into the other core components of integrated behavioral health, and then asking about how things have adapted and where they see it continuing to go. And so I did a qualitative interview with 20 clinicians working in different primary care settings in the spring of 2022. And here are some of the themes from the interview that we found. We heard overwhelmingly there was a permanent change in the physical structure of the team. So on the left, you'll see the quote where certain departments of primary care were permanently moved out of the clinic. So for this, they said psych was moved to telehealth, and it remains so, psych being psychologists. So that part of the team was no longer physically housed within the primary care clinic. And on the right, you could see that there was another thing happened where there was a lot more hybrid models where people would work in person 2 days and at home 2 days a week. But this kind of created this varied structure with sometimes you were with your team and sometimes you weren't. There was an increased reliance on technology for team communication, and some folks described that not being too bad, because with the electronic health record, they could have this team sort of chat within it where they could talk across the team. But others really described it as a waiting game, where you didn't know which way or which technology to use to touch base with the team members, and you didn't know when to escalate that message based on the patient need. Team collaboration shifted and was often occurring asynchronously. Asynchronously being that they would send a message and then 3-4 hours later, someone else would respond, and 5 days later, someone else would respond. And they were kind of working together, but it was not happening as rapidly or in vivo. Some describe that if they had a pre-existing kind of collaboration, that they were fine moving forward because they'd already built that relationship and they were able to contain it. But for others who were new, that was much more difficult. And some folks really described in that bottom quote feeling very siloed, that they weren't having in-person staff meetings, and they didn't have that bumpability, which is literally meaning bumping into people in the hallways and having that opportunity to build collaboration. There was a strong embrace for telehealth, and there was a consideration for pros and cons to this model. But overall, they thought that it's not something that's going anywhere and that it can be a great way to increase access to care. It decreased the no-show rates for behavioral health visits because folks who might need childcare or transportation were able to kind of hop on a video call when they would have kind of missed that appointment. But they were also mindful that for certain populations like older adults and those without technology because they're under-resourced, that this was maybe creating inequities in the care that they were able to access. So I'm writing up these results right now, so I'd love to get y'all's thoughts, but really thinking about where do we go from here? Is this an interruption in integrated primary care, or is this innovation? Certainly right now, tele-delivered care is here to stay within the US. We have a regulation and payment now that allows for it. And telehealth for behavioral health remains high, with 25 to 35% of behavioral health care still being delivered remotely. But this also kind of, and at the same time, hybrid and virtual teams seem to be here to stay. So with this in mind, really considering how do we test the effectiveness of these new models of care, and how do these kind of virtual teams really kind of align with things that we might need to think about for payment, regulation, training models, and clinical workflows that support the patient, but also support the team's communication and collaboration. That's it. Thanks so much.
Thank you, Brianna. That concept of interrupted integrated care is interesting, and I'm really intrigued by the different themes that your research has identified and whether it's an innovation or not. So thank you very much. So Ivy, are there questions too?
Yeah, so there are 2 questions that have been already put in the Q&A. And so I will read them unless Andy or Aaron, you would like to unmute and ask your question. Andy's question is very personally based. Kath, as a health workforce analyst and a UK parent of a newly qualified GP who is now working in Australia, which he noted yesterday, what can be done to attract back the lost workforce? So quite serious, but he doesn't want it to be done before he gets to visit his daughter in Australia. So that's number 1. So that's to you, Kath. And Aaron, this is a question to Susan. Can you define self-regulated for the international audience? So what does that mean? And recognizing that we had a session earlier this morning about health practitioner regulation. So are these non-licensed, non-registered practitioners? Is there a defined scope of practice, and who determines that? So if you can address that, and then we can come back. I've posted Brianna, because I can't post to the Q&A, but I can come and speak to the question that I have to you, Brianna. But to Kath and Susan, please.
Yeah, I wish I knew. I mean, actually, I've just been sort of thinking, because one of the things is we don't really know why people are going. I mean, my colleague Sharon, who I think is on the call, who led the project I'm talking about, did an earlier project which asked people, newly qualified GPs and young people just coming towards the end of their training, whether they were planning to leave the UK, and quite a lot said they were. And one of the things they said was that they felt they that GPs were more respected in Australia and New Zealand than they are in the UK. And there has been a kind of anti-GP mood in the press, and to some extent we have a very hospital-dominated health system, as I think many other countries do, and there's a sense that primary care and general and GPs are just not respected, and income has gone down, compared with international comparators as well. So I think there's a lot of things going on, but it just made me sort of looking at the people on the call and just thinking about I'd love to actually, if somebody would pay my expenses, I'd love to go out to Australia and New Zealand and find all the English GPs and ask them, the British GPs, and ask them why they're there. But I think that we just don't know, and I think we've got to make primary care more attractive. But again, we seem to have this sort of toxic mix of things going on, and we haven't nailed what are the modifiable things in that. Obviously workload is a big one, but which bits of it are modifiable and in what way, and what would make it more attractive? Because a lot of the things that we've got going on, I think, make it less attractive So that, that's one of the problems, because, telehealth, great in many ways, but actually, a lot of GPs like seeing people face to face. And, so there's a lot of things we're doing to cope with the workload that I think are making it less attractive. So I think we've got a real problem, and I don't think we've even scratched the surface of knowing how to solve it, which is why things like this international collaborative is so good, because we can, it's good to know in some ways that, the UK is not alone.
Thank you, Kath.
Susan?
Yeah.
Thanks. As an Australian, I would concur with what you said, Kath, and I know I'm not meant to be answering your question, but and having lived in the UK, I think that the medical model is much stronger in Australia, which still gives the medical profession a level of respect compared to other professions. And I think, and that's, again, I think it's partly the fee-for-service model that we have here that reinforces that. Erin, self-regulated workforce, I'll give the potted answer, but as Ivy said, there was quite a long presentation on this earlier. Using those examples that I gave in my presentation, only a small number of allied health professionals are regulated under national regulation, so by our national regulator, the Health Practitioner Regulatory Authority. The rest are self-regulating, and what that means is their professional associations have set up standards of entry that are essentially equivalent to what is expected under national regulation, but the registration of that workforce is managed by the professional association. It's not compulsory to be a member of your association, and in Australia they don't get protected professional titles as they would under national legislation. Almost everything else in terms of the management of the workforce is equivalent. What's important, though, is that those self-regulating professional associations, and one I've worked with recently is speech pathologists or speech and language therapists. If you're a speech pathologist and you want to get access to national funding under one of our insurance bodies like Medicare or our National Disability Insurance Scheme, or even private health insurance, you need to be eligible for membership of that association or that registration. And in fact, in most cases, you actually need to be registered by the registering arm of that association. And so that, I mean, this is going into too much detail, but we recognise that as co-regulation, where a third-party provider is actually doing the regulatory function, but government recognises that and rewards it with payment. I hope that answers your question.
Thank you, Susan. Ivy, is there another comment up there?
Yes, so Andre has provided a bit more background to your question, Erin, that augments what Susan said. So I will take prerogative and ask two questions, as I noted, one to Brianna. So I found your slide on the importance of primary care in rural areas to be very important for behavioral health. And that speaks to the importance of how allied healthcare providers can augment to help improve, enhance access to high quality care, to use the words that Susan has mentioned. And I was wondering if you had any data on the availability of allied behavioral health providers, similar to what in an earlier panel, Steve Holloway presented in Colorado. And also, like, does the increase in telebehavioral health overcome some of these disparities in geographic availability? So that's to Brianna. And then Louise, I'm just going to ask, Kath provided a sort of a cautionary tale, of integrated care, right? And so I'm just wondering how you would respond to that, from the team primary care perspective, from the project that you provided an outline to. So thank you.
There's actually some great data out of, I'm going to blank on the acronym WWAMI, which is at the University of Washington, that looks at rural health. It's a rural health center. Rural Health Research Center, and looks at the rural urban variations of different types of behavioral health clinician types, including maybe this allied behavioral health. And unfortunately, you will see kind of what you see across the US, that there are a lack of providers of all types in rural areas. And, it's interesting, I think a lot of times integrated behavioral health is used in maybe the opposite of what Kath was mentioning as a way to free up primary care clinicians from having to spend an hour and a half doing a suicide assessment with someone with a behavioral health need, or doing brief behavioral health interventions with someone. And so I think the kind of the tricky thing with looking at allied health and also behavioral health clinicians with the data that we have is we're not quite sure what folks are doing when they're co-located with a primary care physician, and because they might have a scope of practice that varies across different kind of things that they might be doing. For example, licensed clinical social workers are one of the largest behavioral health providers in the US, but they also do a lot of social care. So if a social worker is co-located, it's unclear what they might be doing. And that, my guess, would be similar if it was a speech language pathologist at a primary care clinic, what might they be doing, as well as like an occupational therapist. There is some good data I'm happy to put in the chat. In terms of telebehavioral health, it's so fascinating because I'm doing another study that's looking at the rates of telebehavioral health in community health centers using kind of secondary data. And it's almost like the embarrassment of riches. So places that have higher kind of proportions of community health centers in urban areas are actually more likely to be doing tele, and the rural areas are less likely to be doing tele, which is contrary to what that they maybe have originally imagined. That could be due to like broadband or internet issues, access issues, but I kind of anecdotally heard through talking with these community health center administrators, rural areas have a higher rate of stigma and bias and kind of this kind of maybe lack of inclination to want to engage with behavioral health, and that doing it in person for some reason kind of reduces the stigma of receiving behavioral health care. But I think that's something I've heard a lot, is that there are major inequities in telebehavioral health. And that's something, it's increasing access, but for who is something to watch for.
Thank you, Brianna. Louise?
There are some interesting things going on in the chat, which I think are related to what I'd like to say. I think Kath raised a number of really important points, which I think speak to the fact of sometimes when we decide that we're going to build these teams, we actually forget that they have to meet patient or population need. And when the family health teams were first brought into Ontario, one of the provinces in Canada, this was probably over a decade ago, one of the first things they asked groups, usually starting with a family physician, tell us about the population you're serving. And then from that, you determine the health professionals you actually would need in your practice to meet those needs, rather than saying, I want one of those, one of those, one of those. Because if you do it that way, you start to then understand that you are making sure that you are going to be bringing on the right people. But I think Kath or someone else mentioned the fact that not every nurse practitioner has the full scope. And some of them might come in with a reproductive health, some of them might have a particular area. If you don't determine that from the start, you potentially will have a mismatch right from the get-go of your team members, of being able to provide those complementary services. Then the second piece of all this has to do with being able to make a practice run. And if indeed you have the duplication that you occur, I think Kath, you talked about duplication, you talked about the fact that the what we call medical officers, MOAs, medical office assistants, don't actually know what the individuals behind there are doing. They don't know how to book even the patients and their requests. So there's an awful lot of organization, of planning ahead of time, which, yes, we can cover a little bit through our educational systems, but it needs to happen at the level of the practice. There need to be investments done to help individuals understand how do you organize your practice, how do you ensure that everybody's on side, so that the patient actually can access the right practitioner at the right time for the right issue. And when it's done well, patients really love the system. They don't say that they're being punted along or that they have to see 2 or 3 or 4 different people. You can plan it that in one visit, they can see the pharmacist and the nurse for their foot care, et cetera. They don't have to keep coming back. But that requires an awful lot of investment right from the start so that everybody understands that. Well, I'll stop there.
Yeah,
hopefully
and
I've
I
addressed that.
think you're you're absolutely right. And I think from our perspective, you know, the practices were working really hard, but I think for me, that the kind of the policy learning is that as you say, it takes a lot of investment, training, engagement, and it doesn't save time. You know, that there's a kind of thing that you're going to free up people's time, and I don't think you do. That's not to say you can't make these systems work and provide excellent integrated care for people, but there's a sort of false narrative, I think, around it.
I agree. I don't think it necessarily frees up people's time, but it actually might make them do what they should be doing instead of things that they shouldn't be doing.
Yeah,
right.
No, absolutely.
And there's some of that. The other thing I would comment on, though, Kath, is the thought that, and I'm a family physician, I retired a few years ago, that only seeing really, really complex patients all the time is exhausting. And that is not something that's going to promote the health and well-being of our family physicians. So you do need to make sure that that sort of thing doesn't happen either. I think I'll pass this to Susan.
And I think there's
Thanks.
a question now
Yeah,
from the floor here. Yes,
Oh, no, Susan.
Susan.
Yeah.
Okay.
Sorry, we've got two chats going and one's not public to everyone. In fact, Louise and Kath, you've raised the point. Kath raised the point, and I'm probably reframing it that, and I think it's sort of a topic for this panel is, you know, in integrated care and actually in interdisciplinary care, we're breaking ourselves down into a bunch of tasks, which kind of disaggregates the profession. And Louise, I loved your slide. I tried to count the number of different allied health professions that you had, and I couldn't quite count quickly enough, but there were more than 15. And you're right that it's impossible to have access to all 15 in most of our primary care settings, I would say, ever. And the more you move away from a metropolitan setting, the less likely you are to be able to access those people. And so we're seeing what I would call a multidisciplinary practitioner who takes on bits of those tasks rather than having access to 15 or more different members of the team. I guess my question is, where do we draw the line between, you know, the jigsaw puzzle of handing around competencies versus what is actually left for a profession? And, you know, is it just the hard stuff or is it a care coordination role? And how do we stop ourselves from burning out?
Yeah, and I think that's a really difficult question, and I think, you know, it's what makes you want to be the professional providing family community-based care, and I think we are. That there's I come at this from a policy perspective because I spend a lot of my time doing research for policy, and the sort of there is particularly in the UK, our policymakers talk about in a very task-based way. The bright idea that's coming around at the moment is that you can separate out urgent care from sort of ongoing care. But of course, the people who present needing urgent care are also people who have ongoing problems, and you know, you can't. The two things. It's not like they're different people, you know. I worry a great deal. I do, you know, and it might be my age. I do hanker for an approach which allows you to do whole person care, which allows you to deal with with support from your highly qualified colleagues. You know, in a more, as Louise says, where you have a system that allows that integration that works really well, but we're miles away from. And I think one of the things is UK general practice, and I think it speaks to what Louise said just now, is undermanaged, massively undermanaged. And I think we really underestimate at our peril the amount of kind of administrative and managerial work that needs to go on to make sure integrated care gets provided properly in a way that's holistic and allows us to move away from, because I mean, nurses have been railing against task-based care for years, haven't they? And you know, it's not the route to a fulfilling role. But then actually we and again, you know, it's really interesting because of course I trained before the note that when competencies weren't a thing when I trained, but now we're training to competence. And again, I that's one of the things I think, really, we really talking about training us around competencies. And that's why I like I think Louise, your vision and you know, all of that vision and mission, rather than here's a list of competencies we're going to train you to do, which fills me with dread.
I mean,
you.
I'd love to add something that, because I cringe when I think about tasks, but I think what can happen, and again, this is where if you understand, if you are part of a team, and if you have a lot of turnover in a team, it's not going to help, right? But if you can have a stable team and you start to learn what each other does, there will be overlap. There'll be things that I do that the nurse practitioner can do, et cetera, but we don't get into a fuss about that, right? It's not about replacing me, it's about complementing. And there are times, and I've worked on teams, and I was lucky enough to work on teams where sometimes the nurse would do this and sometimes I would do it. It would depend who was seeing the patient at the time. And then we shared. And when I wasn't available, she was available, or if there was something I couldn't do, I was able to, have somebody else do it. So you start to understand the flow, but it's from the patient's perspective. It is not from the practitioner's perspective. But that takes time. It takes relationship building. It takes trust in each other.
And the more we have turnover, you're absolutely right. The more we have people come, leaving because they're finding the role too hard, then the harder it is to develop that, and then the patients get a raw deal. So yeah.
What a great exchange of ideas. Thank you. We have a question from the floor here. Steve?
Hi. Yeah. Hi, everyone. Good to see everyone. And I'm Steve Slade. I'm the Director of Research at the College of Family Physicians of Canada. I do have a question. And even just listening to this conversation here, I can't help but feel, a part of me, that when you start to think of primary care and to define primary care by using professions, that it just seems like such a rabbit hole. I can't imagine that when I look at your lists, Susan, like the audiologists and the social workers and the psychologists and the counselors and the exercise physiologists, et cetera, that in an encounter with any one of those people, that they are not seeing the whole person. And so if whole person care is kind of a part of primary care, then are they all part primary care? I notice on the lists too of the allied professionals, there are not physicians and there are not nurses. So physicians would include surgeons, include like family doctors, but also pediatricians and internists and obstetricians and psychiatrists who may themselves see them playing roles in whole person care and in stages, maybe at times in a person's life, and perhaps for significant parts of their time being a primary care provider. So I guess the question really, Louise, it was triggered by your opening comment really, and I do think that you're on the right path there, is to figure out what are the domains of care, within primary care, rather than to try to define this in some proxy sort of way vis-a-vis the health professions, but to actually try to hone in some ways. Is it about first contact care? Is it about ongoing chronic care? So to try, and I don't know if you have an emerging picture coming out of that interprofessional collaboration table where is there any consensus beginning to emerge? And it's actually hard to believe that this has not been a body of literature and research for some time to actually define what is primary care. So I do wonder what those domains of primary care are.
I mean, I can't really answer that question because it's a tough one, Steve. I think, there's been a lot written about what is primary care. And at some point, I think we just need to accept the fact that there probably are going to be different ways of looking at this. What was helpful to me, because I have to admit, I was starting to find my head was bursting as we were moving through this project, is I had to come back to what happens to the patient. A patient who comes into the system somewhere, which that first contact was actually really important for me to understand, is they can come in, they can access a system many different ways, certainly in Canada, even though in Canada you can't necessarily see a consultant physician without going through your primary care provider. But nonetheless, you can see your pharmacist first, you could see a lot of different people first. But what happens after that is really critical, because if I, as a family doctor, refer to a dietitian or refer to, or the pharmacist sees the patient first, the pharmacist needs to start thinking about, it's not just what I'm doing. This patient is part of a broader system, and there are other providers out there, and how do we work together? So to me, that notion of complementarity is really critical. and being able to get people to start thinking that way, that it's not just, it's not just the task I am doing, it's the overarching care and how does it fit into that. That's how I sort of see this primary care system working. And we are far from having that. So call it integrated, whatever. That's not the issue here. It's really being able to take it from the patient's perspective. You probably ask them and they will tell you what it should look like.
Thank you, Louise and Steve. Susan, you have a follow-up?
I just wanted to add to this because I think it's a great question, and give hopefully a very quick example that was undertaken in rural and remote Australia. So the challenge that they had was getting, for a small population, they couldn't get multidisciplinary teams there. There just wasn't the population to support it. So they did a population needs-based analysis using a UK-based tool called the Calderdale framework. So again, it comes back to tasks and competencies, but they looked at what the population needs were and identified, I guess, a list of jobs that needed to be done. And then they had 6 allied health profession groups that could potentially meet those needs. So physio, OT, podiatry and so forth. And they put those tasks back together instead of around professional bundles, around need bundles. So there were things like pediatrics, mobility, improving, I can't remember, I think there were 12 different bundles, but they were not profession-based, they were function-based. And then they looked at the roles that those professions did and the tasks and the skills that they had to meet those needs. And they did actually put them into competencies and create multidisciplinary practitioners who could meet the needs of someone with mobility or meet the needs of someone with hearing impairment, rather than necessarily having the audiologist doing that task. I realise that's a different philosophical basis to sort of the family physician model, but it is, I think it's getting to your point of, instead of seeing the person as a tool for professions to do their stuff to, as seeing the needs of the population that we've got.
Okay, thank you, Susan. Okay, so let's thank everyone who presented today on this panel. A great job and a wonderful conversation. So thank you.